question is, someone who had a chronic autoimmune disease was diagnosed with a grade 2 neuroendocrine tumor with a adenocarcinoma, so a cancer component to it. And it was thankfully completely removed with an endoscope, so by the camera, and usually by scooping it out, I presume. And the question is, how do we follow these patients? And so this gets to some of the survivorship and gets to some of the monitoring, which really we didn't have time to go deep into. But I guess I'll start with Dr. Gung because he's a medical oncologist. So I don't know, what do you think for monitoring?
So that's a really good question. It's actually a pretty rare tumor to have both a neuroendocrine tumor as well as the adenocarcinoma. But in general, neuroendocrine tumors, Dr. Klepner and I were talking, they do sometimes occur in the setting of chronic autoimmune gastritis, which I believe is what this individual had. But in any case, when this tumor was completely removed endoscopically, we do tend to place a lot of the weight on surveillance on the more, what we call probably biologically aggressive type of tumor, which is the adenocarcinoma component of it. So we would be more diligent focusing on the adenocarcinoma surveillance rather than the NET surveillance, because the surveillance for NETs is a little different. It's with different tests, different markers, even sometimes different scans. But adenocarcinoma in the resected setting is followed with some standard tests, history and physical, CA19-9 scans, as well as following with the surgeons as well.
Can I add to that? If it was an endoscopically resected tumor, whether it's adenocarcinoma, probably very early stage, or neuroendocrine tumor, you need an endoscopy to surveillance that, unless you're looking for metastatic disease. So if you're looking for local recurrence or additional neuroendocrine tumors that may arise in your stomach, you need an endoscopy. Usually, probably annually is sufficient. And so on top of some of the biomarkers that you may want to get, you should get an endoscopy.
Yeah, I would totally agree with everything that was said. Next question, this is really for everyone on the panel. So this is a big issue beyond stomach cancer. Certainly we've seen this in colon cancer, but why are we seeing more young people under the age of 50 being diagnosed with stomach cancers? And I guess I'll let everyone take a crack, and then I'm happy to weigh in as well.
Can I say something?
Yes.
So while I was slightly over 50 at diagnosis, but I still feel very young, I did test positive for H. pylori, and I assume a lot of people here and those who are watching understand what that means. I come from a third world country, Argentina, where routinely young people get tested for H. pylori and treated for H. pylori. Also at the age of 50, when they get their base colonoscopy, they get a base colonoscopy and endoscopy combination. I didn't get any of that in this wonderful first world country of ours. So part of my plight, my fight, what I am trying to achieve is for standard routine H. pylori testing and treatment and recurring testing and treatment. You don't just test and treat once. And also, in my opinion, we should all be getting standard routine endoscopies together with colonoscopies, and we shouldn't be asking for them or fighting with insurance. We should be told we need them. Had I gotten my endoscopy at 50 when I got my colonoscopy as prescribed, I would have been stage maybe 1. So just a little bit of food for thought for all of you.
So just to follow up with Marissa's, it is true there is a trend of increasing younger patients with not just gastric, but as Sam said, probably with other diseases like colorectal. It is one of the, we are aware that is happening. To find out why is very difficult. For gastric cancer, it may be the increasing incident, well, there's a decreasing incidence overall, increasing incidences in certain patient populations like young Hispanic men in Los Angeles. And why is this happening? We're not sure why. Is it the increased incidence of H. pylori in that population? Is it environmental? Is there an increasing incidence of germline changes in the Hispanic population? East Asian population is increasing, is the fastest growing minority, and perhaps that is increasing the risk. So there are efforts for patients for population that has moved from third world countries to the United States. There's an effort and recommendations to screen them earlier. And people are working on this, and we need more information to make guidelines not just cost efficient, but life-saving.
Yeah, I would totally agree with what Yang and Marissa said, and what Ben and June talked about. I think it's really about risk factors and finding the people who are at the greatest risk and maybe targeting them for screening. In Korea, for example, when you turn 40, everybody gets an endoscopy. They have a national program like we have for colonoscopies, and they have the best outcomes in the world, and part of it is certainly because of that. And so I would echo those thoughts. I know this is something that Yang has actually done some work on. Also wanted to just recognize one of the people who has done a lot of work individually for H. pylori, who unfortunately passed away, was Brandy Carrasco, as was put up in the video in the beginning. I know a lot of people here have known her and been involved, so recognize her work. Yeah, about 10 more minutes maybe or so for questions. So anyone in the audience is certainly welcome to shout out.
There's some questions out here, guys. Don't be shy.
I have a question. Come on.
Well, do you recommend just more H. pylori testing? Well, using blood. I know the standard is, something like a helium bag. But, is that a simple thing? Very economical? What do you think?
H.
Anybody?
pylori testing is the easiest test ever.
Yes.
You breathe into a bag, you then drink a substance, you wait a few minutes, you breathe back into the bag, you go home. There's no reason for my 13-year-old son not to be able to get that test. It's just crazy.
It is crazy.
I know.
And I think just more public awareness
Absolutely.
is very needed, don't you? I mean, even the physicians.
Absolutely.
Why aren't
Yeah,
they
yeah.
doing more?
One of the things patients have to do, the doctors in this room are not the best example of what I'm going to say, but most doctors need to be educated. These doctors here with us are the exception. So when you meet with your doctors, don't assume they know everything. Challenge them, educate yourself, because most doctors are not up to date with everything, and they don't even realize how basic H. pylori testing is. It's very affordable too, and it's covered by insurance.
Just a quick comment. I used to live in Florida, and I had this nurse practitioner friend, and I just said, hey, just do more H. pylori testing. She started doing it. She came up with a lot of people, and she derailed that cancer diagnosis,
Yeah, I think, a lot of us are in the oncology side, so by the time, unfortunately, the patients get to us, a lot of times
Right.
they have a diagnosis of cancer. So although we try to educate people on the topic as well, I think there is a need for education at various other provider levels, primary care, nurse practitioners, just general public awareness is certainly there's a need.
I think this is a challenge for stomach cancer, especially in the United States, because of the low incidence in the United States. But there are risk factors that we should know about, like family history, untreated H. pylori infection. If you treat, and it's very easily detectable and treatable. Those things exist. And knowing germline mutations that may cause this. Everyone knows Lynch syndrome causes colon cancer, but do they know that it is also a risk factor for stomach cancer, and what to do with that? And so, CDH1 mutations are being tested in patients with lobular breast cancer because it was associated with breast cancer, and we're finding a lot of CDH1 mutation variants that are now putting patients, especially women with lobular breast cancer, at risk for stomach cancer. So increasing awareness about the risk factors, asking for testing when it's appropriate. It's not just one factor that's going to lead, it's also environmental, smoking, drinking, things like that. And so we need to know about those things.
Let me just add a comment here. The germline testing or hereditary testing is now available direct to consumer. And the pricing for these tests has come down to, I think, $200, $250 a test. There is a genetic counselor that is provided with the test so that you can talk to a genetic counselor about the test results. So I think this might also help improve access to these tests and make them more available to especially this community.
All right, we got time for one more question and then lunch.
So my husband has stage 4 gastric cancer, signet ring diffuse, and he has had FOLFOX, which he was on for 12 cycles, and then now he did not respond well to Cyramza and Taxol. Now he just started Keytruda. So I wasn't sure. I've read in a few places that sometimes they combine Keytruda with chemos for third line. Is the reason why he would not be because he's already been resistant to those, or is he on the standard? I know you don't know my husband.
I'm
but
happy
just
to take
curious.
that one. So I presume that he is PD-L1 positive, and the data is exactly what he has done: FOLFOX, Taxol, ramucirumab, and pembrolizumab for people who are positive. So he's following what you could argue is a very standard sequence. Combination in the third line setting is something that comes from the idea that basically in the third line setting, Keytruda alone works for some people, but not enough people, I think in everybody's opinion. And so how can you increase the percent of people that it works for? Combinations is one of the logical ways to do that. There isn't big sets of data that says that's what you should do. We don't have trials that say people who got the combination live twice as long as people who got the one drug. We all want that, but we don't have it. So the standard is to get one drug. So he is getting the standard thing. I think it's important to watch these people pretty close because if the drug's going to work, it works. But if it's not going to work, it also doesn't take very long to figure that out. So I tend to watch those patients a little bit more closely. And by that I mean maybe a little bit earlier scan than you would normally think. Again, I think it's an important place to think about making sure that you've explored all the options. So all the additional biomarkers that everybody else was talking about, I think is something that I would want to at least have a sense of. But to answer your question, that is the standard pathway, and that's exactly what the guidelines basically say.
So, just clarification. So Keytruda, they said 3 or 4 doses before they can really tell. Is that really?
So that's,
I mean, obviously they just said compare the week previous to see if he's getting better or worse, and just kind of watching it. He's on TPN.
Yeah, so it's a good question. We assess if it's working by a bunch of things. One is how patients are doing. If they're feeling better, they're eating more, their energy's better, that usually is a good thing. If the drug's going to work, you're right, the average time to see if it's going to work is probably in the 7 to 10 week range, so in the 3-4 doses. I think sometimes we'll use an early scan because you can tell, not if it's going to work, but you can tell if it's definitely not going to work. So if you scan someone at like 6 weeks, you may say that it's definitely not working. Or you may just be reassured and say there hasn't been much change, let's keep going. I think in later lines when things can happen a little more quickly, we may watch people a little more closely, but that's just personal practice differences. I don't know if anyone else has thoughts.
No, we had a conversation. She's asking because we had a conversation last night about MD Anderson on some patients. He's using Opdivo and chemo. So I just said to her, why don't you ask Sam tomorrow what he thinks about that? But it was very specific, a couple cases. I'm thinking maybe that the particular patient I'm thinking about could even be on YouTube right now, so I'm being cautious, but it's a combo of Opdivo and chemo.
Yeah, have I done it? Definitely. Has there been studies? Definitely. But just to give you the correct answer, there isn't a huge amount of data for that. Does it mean you can't do it? Not at all. I think that there's definitely been times where, the immunotherapy has stabilized the disease, but you want to try to add on to it. So, yeah, I think it's not unreasonable, but it wouldn't necessarily be the standard thing at all. It's lunchtime. It is. I'm trying to keep it. It's 11:32.
We're 2 minutes over. If you have another question.
Yeah. All right, we can do 2 quick ones.
Test result. Where can I find what are my biomarker?
Where can you find what your biomarkers are? So,
My test results.
yes, depends on the organization.
I'll send them to you.
Yes.
Dr. Chow has them.
I can say for people who don't have stage 4 disease, there isn't really a standard for assessing all those biomarkers we talked about. So stage 2 disease, it would be not uncommon to have none of those tested. When you were diagnosed, for example, that data about MSI high in the stage 2 and stage 3, that wasn't even out yet. So it's possible that you haven't had that. Doesn't mean you can't easily add it on to your tumor, but if it's available, it would be at the institution you're cared for. So like Dr. Wu said, City of Hope would have that. All right, last one.
Okay, it was a follow-up question on the gentleman's question on the biomarker. When our daughter was diagnosed in 2015, we did the Foundations 1, and it was not approved by insurance, or it was not even, approved. So I don't know. It's been 4 years. She had a 20-month battle, and she was one of the youngest patients of Dr. Klumpner who had expired. But I would like to find out if insurance covers it, because it was a $5,000 bill for Foundations 1.
So
Yes, go ahead.
I have 2 bills from Foundation, $4,200 and almost $10,000 for first and recurrence. We had this conversation last night. No, most insurance will not cover it. They will deny it. I did 2 appeals with each just to have the proof. I then went back to Foundation, and because I'm on long-term disability, I went through the process of financial assistance. It is a huge gap in care. Because not only did I want the testing, but my doctors ordered the testing. It's not like they consulted with me. I'm treated at Stanford. Testing was ordered, I get the bill. So it's a big challenge. And every attempt that people have had with PPOs, we are not even talking Kaiser, PPOs is denied. And it's a huge gap because you say to the insurance, my doctor needs it because I could be a candidate for currently available or soon upcoming targeted therapies, and they still consider it experimental. It's not standard of care.
So I don't know what happens at other institutions, but there are institutions who have internal testing that actually is, I don't know if I'm allowed to say this online, but is billed but not collected. So for example, we do at City of Hope testing for the biomarkers internally. It's provided to the patient and offered to them, and it is at no cost to the patient. And I don't know I think other institutions who do clinical trials and clinical research may have this, but available as a clinically usable set of data that is returned to the patient or to the physician if needed. So things are changing over time from 2015, even 2017. This is brand new for most of us, especially, in this world of the rapidly increasing testing. There's now no longer is it just Foundation 1. There's many other tests, companies that are coming out with this. So it may be easier to get nowadays. I don't know when the insurances will follow up with that. I don't know, Sam, has your experience.
I don't know, Ben, if you want to comment.
Yeah, you see quite a disparity of adoption across, different levels of cancer centers. You have the research institutions where they do a lot of the testing in-house, and it's a standard practice for lots of those places. once you get away from those, it really is kind of hit and miss. I will say, I work with Foundation Medicine. They do have financial assistance. They generally they have a high rate of providing assistance to patients if they can't get a reimbursement for their tests. Generally speaking, though, if the treating physician will sign the order, it gets covered. There are times where that doesn't happen, and you really have to be your own advocate and get additional opinions and find the right place to get the right level of care, because we do see that quite a bit.
Yeah, I'll add one clarification is the standard biomarkers, so HER2, PD-L1, and MSI status are covered by insurances because that is standard of care. So that should always be covered by insurances. The extended biomarkers, like the things I talked about, EGFR, etc., those are things that are still considered research by most insurances, but I totally echo what everyone has said. I've done this well over 1,000 times for patients, and I looked back at our data, and I can't think of a patient that I've had a bill more than a couple, like $200 after going through financial assistance, etc. So I think the companies are actually, they want to provide the service, and they do want to help patients because they recognize it's a massive cost. But I think it's a conversation that should be had for every care team. I'm going to wrap up the morning session because it's lunchtime and we've got some really good lunch speakers. So thank you all. This was a great morning session, and lunch is right around the corner.